So let's talk about headaches. And headaches are important because a large portion of our population suffer from headaches. As I said, up to 12 to 18% will suffer somewhat regular headaches. I'm going to make it relatively simple. I'm going to split it into tension headache and migraine headache, as they have two different sources of the pain. First, the tension headache is the classical pain around the side of the head, sometimes forehead. You may feel some eye pain as well, and even pressure in the face, and a lot of pressure and pain down at the base of the neck. In general, my take on the origin of this will be, again, much like the tennis elbow, there'll be deep spinal muscle injury and shortening and scarring, causing compression of C5, 6, 7 in the general territory. This will affect both the sensory and motor nerves in that area. The sensory nerves may refer pain to the side of the head and front, but also there'll be a motor nerve effect where the motor nerves cause the trapezius muscles to shorten intensely. And the trapezius is a massive muscle, technically the strongest muscle in the body. So when it gets a neuropathic drive behind it, it really shortens up and scars up intently and can be extremely resistant to therapy. And that will cause the whole neck to actually compress somewhat and lift the shoulder blades and shoulders a bit. And that can be one of the easy triggers when someone experiences some stress. If they already have this scenario in place, they have a stressful day, it causes the trapezius to shorten, come up that little bit more, and boom, they got the tension headache. The treatment for a tension headache, therefore, will, in the basic sense, will be treatment at the base of the neck, dead central, all the way down to the deep spine, and then also the surface muscles of the trapezius, and sometimes other muscles in the neck will have to be treated. That's the basic tension headache. When we talk about a migraine headache, we really refer to that as a vascular headache, as the vessels dilating in the front of the head, and that's typically a neuropathically generated dilatation, or cervicogenic, I should say, which means neck generated, but also neuropathically from the neck. In general, the areas identified that trigger the classic migraine are from the high neck, usually there'll be a compression syndrome from the bottom of the skull, the occiput, to C1, C2, or the first 2 or 3 vertebrae, where there'll be constant or intermittent compression. If it's constant compression, the person will have fairly chronic headache. If it's intermittent, they'll have frequent headaches. And it doesn't take much to set it out. So it could be sleeping improperly one night, and that's why a lot of migraineurs will awake at 3 or 4 in the morning with a migraine, is that their neck position, usually they're lying on their side, they'll have a slightly flexed neck position, which increases that little bit compression just enough to cause the lateral nerves, the nerve roots, to be compressed and affected, and then the referred pain will trigger. The classical referral areas will be the eye, and sometimes you get the poker in the eye. Sinus will be usually affected, and it'll be constant stuffiness and congestion of the mucosa of the sinus. Facial pain, jaw pain. The jaw muscles, the masseters and pterygoids, can become rock hard, just like the tennis elbow. So that similarly, it's nerve-generated muscle shortening with trigger points, and the dentist will often say that you're grinding your teeth. That'll be an early indicator. You're grinding your teeth at night because as you're sleeping, the neck is getting a little tighter, and it's driving the jaw that little bit tighter to grind your teeth. When it's more overt, you'll actually have jaw pain, dental pain, that becomes obvious. So when we see car accident victims, we often see this pattern of eye pain, sinus, facial, jaw, and there will often be functional symptoms as well. I mentioned before about tinnitus and vertigo. So the high neck is often associated with triggering a ringing in the ears and a bit of an unsteady vertigo where you're bumping into walls. And this is brought out more at night when you get up to pee and the lights are off and you don't have visual cues to help you, and so you start to stagger into the walls, and that's often an indicator of high neck issues. Not always, but it can be. Finally, I just want to make one more point about sinus congestion. One of the triggers we found is that for sinus congestion is we'll see that when these people have high neck neuropathy, the mucosa actually becomes more hypersensitive to allergens than they otherwise would be. This is actually a concept called Cannon's law of denervation supersensitivity, who was able to show that when you denervate tissue, it becomes hypersensitive. And so the denervation or nerve impairment of the mucosa causes it to become hypersensitive to allergens that would not otherwise be. And so this is where we see people who have car accidents who develop new cat allergies and environmental allergies that they never had. And if you look at the chronic pain group as a whole, they have a massive amount of allergies that much higher than the average population, which is likely related to this irritation and this Cannon's law of denervation supersensitivity. It's just a point to keep in mind. Not absolutely proven that the Cannon's law is, but the allergy component's not, but it's suspect. The second part is the another conditions that I like to talk about are ulnar neuritis and carpal tunnel syndrome. Ulnar neuritis is when you get the numbness in the little fingers, and the carpal tunnel will be the classic thumb, index, middle, and half of that ring finger. And they are related and often travel together. And the reason why they occur in most cases, or at least this is our opinion at the Lamb Pain Clinic, is again it will be mediated by the spine causing muscle pathology in both the front and back of the shoulder, causing traction injuries, which then cause referred pain down the arms. So more specifically, what typically happens is there's a broader spinal compression, C5 to T1, 2, or even 3, so even getting into the upper back. This causes a motor neuropathy in the front of the shoulder, so the pectoral muscle shortens. That's more a C5-6 problem. This the shortened pectoral will form contractures or trigger points which will pull on the neurovascular bundle coming down here, the median nerve. The median nerve will get this constant pulling and it will rub on the carpal tunnel here, and over time it will swell. If it's allowed to become chronic, you'll get definite pathology here, requiring surgery or some kind of intervention here. However, if it's caught early enough, that can be avoided with proper neck and shoulder treatment, and forearm treatment can often make the difference. Ulnar neuritis is similar, but it's a little bit different. Usually it's the back of the shoulder that will cause pulling on the ulnar nerve, catching in the elbow, and then can be really very painful. And you can actually feel the nerve roll over the elbow as you bend the arm. When there's a lot of tension, that nerve has nowhere to go, so when you bend it, it's going to roll over that outer elbow. It'd be very, very annoying. And although it doesn't get the attention of carpal tunnel, it can be very disabling, and the surgery in this area can be really, really iffy in terms of success. They do these ulnar nerve transpositions, and they can be very dicey. So again, so the ulnar neuritis and carpal tunnel are part of the repetitive strain injury condition, where the tennis elbow is part of it, golfer's elbow, rotator cuff. So it's, as I said, anything that's in the arm and shoulder is the RSI. So the treatment for these conditions will be a more broad treatment of the neck, upper. So to review, for repetitive strain injuries such as carpal tunnel and ulnar neuritis, I tend to recommend a broad treatment where the full neck, upper thoracic spine, front of the shoulder, back of the shoulder, arm and forearm is treated. So we get more of a carpet bomb treatment of just treating everything, because I've seen where there's muscles that have been omitted that were still contributing to the pain condition to continue on even after a fairly broad spectrum treatment. And so I tend to say just treat everything in these conditions, because I find that there's often latent trigger points and latent scarring that we're less aware of that can be contributing to a referral of pain down the arm or hand. And that also includes treatment of the shoulder blade as well.